So the next speaker is myself. My name's David Knoppert. I'm a pharmacist in London, Ontario at St. Joseph's Hospital, and I'm a member of the Department of Pediatrics and Pediatric Clinical Pharmacology at Western. And today I'd like to talk to you about the effect of two different Domperidone doses on maternal milk production. There's not a copy of this presentation in your package because we've submitted this to the Journal of Human Lactation, and we hope that it will be published in that journal in the next couple of months. The history for this goes back into the early 1990s when our lactation consultants asked us if we would prescribe Domperidone for women who are mothers of premature babies who are having difficulty with making adequate milk production for their babies. Because in Toronto at Sick Kids, they were using it quite a lot, and so they wanted us to use it. But there was no literature to support its use. So just a bit of the background. First of all, we know that breast milk has many benefits. It's recommended for the first 6 months of life, at least, by the Canadian Pediatric Society and the American Academy of Pediatrics. Human milk is the preferred feeding for all infants, including premature and sick newborns, with rare exceptions. A number of advantages. In breast milk, there are hormones, growth factors, cytokines, living cells, and immunoglobulins. Preterm infants fed human milk have faster achievement of full enteric feeding, a decreased frequency and severity of infections, and enhanced retinal development, visual acuity, and neurocognitive outcomes. So milk is very important to babies, and especially to premature babies. However, the mothers of premature babies are at 3 times at risk of not producing an adequate milk supply. And the main reasons for these are an absence of suckling and stress. So mothers are capable of producing milk for any viable infant. However, many challenges are to be overcome for women who are mothers of preterm babies. It's unexpected, and having a baby in the NICU places many stresses on the mothers and also on their families. The preterm infants are not mature enough, so they can't coordinate oral feeding until they're at least 32 to 35 weeks gestational age, and they're not strong enough to maintain a milk supply by suckling until 36 to 46 weeks post-conception. And you can see here that we have babies as small as 24 weeks. So preterm mothers must use a breast pump anywhere from 8 to 10 times for 24 hours to artificially stimulate their milk supply. These pumps mimic the term infant at the breast, but are not as efficient and do not provide the same psychological stimulus. So this is where Domperidone came in. And most of you know this as a drug, as a prokinetic. It's a peripherally acting dopamine antagonist, and so it's officially used as a prokinetic. And there's some patients with gastric paresis, such as diabetic patients. However, one of its side effects is an increase in prolactin. And I think back in the 1980s, and I think it was a report from Sunnybrook Hospital in Toronto, that there was galactorrhea, and this was seen actually in men who were on Domperidone. So it's used as a galactagogue in Canada, Europe, Australia, around the world, but not in the United States. In 2004, in the midst of our study, which started around 2001, 2002, the current study, there was a warning from the FDA. And I'll come back to that in a moment. Our first study was published in 2001, and it was basically looking at Domperidone versus placebo, because at that point in time, there was no trial that had looked at Domperidone versus a placebo. People used it, and anecdotally they said it worked, but really there wasn't anything. So we did a double-blind randomized controlled trial in London, and we found that the milk production was 44% increase versus the placebo, which was slightly increased, and that was statistically significant. And we also saw an increase in prolactin, which we expected, and that helped explain the increase in milk production. So we knew that, and this was a dose of 10 milligrams 3 times a day. However, there was continuing uncertainty because sometimes we'd see physicians order 20 milligrams 3 times a day, sometimes 20 milligrams 4 times a day. We even heard stories of women being on domperidone for 6 months. And the dosage, the knowledge, just varied between physicians. And there were no studies as well of long-term efficacy or safety on the mothers who were taking it for this indication or on their babies. Like I said, in 2004, this was from the FDA website. FDA warns against women using unapproved drug domperidone to increase milk production. And you can see in red there, the FDA is warning breastfeeding women not to use this product because of safety concerns. Today, FDA also issued 6 letters to pharmacy that compound products. And I had a look at those letters, and what they threatened was to close down the pharmacies and put the pharmacists in jail if they produced domperidone formulations. They would import this from Canada, and then they'd have produced the formulations in the United States because it wasn't available in the United States. There were some responses to that. One was from Thomas Hale, who several of you know. He's an author, editor of Medication in Mother's Milk. So this is an American to the FDA. This warning from the FDA has nothing to do with its safety. It's all about the importation of drugs from Canada and controlled by this federal agency. And if you think back, maybe some of you can remember, this was a time when the Americans could get drugs from Canada through internet, and this was all happening at that time. So it appeared to an American, and it appeared to us, that this was more of a political situation. At the time, the response from the UK was basically they considered it so safe that it was available over the counter. So that was the response from the UK, and similar responses from Australians. And there was a Canadian response. 2 things. We published a letter in Canadian Medical Association Journal, which I'll just go through some of the details. But the other thing is that during our second trial, which I'm going to talk to you about today, it was sort of in the midst of our trial when this happened, so we put the trial on hold. We showed Health Canada the response, what the U.S. had said, and we waited for Health Canada to say, yes, you can go ahead, or no, we want you to stop. And I think it was about a month later they said, okay, continue on. We had no issues with that. But let me just tell you what the FDA response or rationale was about. There were cardiac arrhythmias, cardiac arrest, and sudden death following IV domperidone. It was early to mid-1980s. There were case reports of this. And this was used in patients who were receiving chemotherapy because they had lots of nausea and vomiting, and this was a prokinetic, so hopefully that they would try that to decrease those side effects of the chemotherapy. And so these are the facts. So one case was a ventricular fibrillation and death, and a 69-year-old patient who got a bolus of 5.7 milligrams per kilogram. So if you take an average person who's 70 kilograms and multiply that by 5, that's 350 milligrams. We're talking about giving oral doses of 10 milligrams. And then he was followed by a continuous infusion. There was sudden death in 2 patients who received 2 milligrams per kilogram. So again, that's about 140, 150 milligrams of IV domperidone. And then ventricular arrhythmias in 4 patients who got, again, 20 to 50 milligrams. And in fact, they were also hypokalemics, which will predispose them to dysrhythmias. The oral bioavailability of domperidone is less than 20%. And when they gave 10 milligrams per kilogram to healthy volunteers, you can see the concentration of 500, almost 600 nanograms per mil following the IV, and the oral was 23 nanograms per mil. So big, big difference between oral and IV. And when they gave these doses, even up to 160 milligrams, the doses was 14.1 nanograms per mil. So the bottom line is that those patients who got the doses of IV domperidone in the 1980s got incredibly high doses. They were probably well over 500, 600, 700, maybe even higher nanograms per mil. And when we give the drug orally, the concentration is much, much less. In some animal work, in isolated guinea pig hearts, it's been shown that prolongation of the cardiac repolarization is extended, and there may be a clinical increase in the QTc interval in patients. So the take-home message, and for us when we were in our study and when we do prescribe domperidone, is that there is a potential for an effect on the QT interval. So patients on this medication have to be aware of drug interactions with drugs that can extend the QT interval, such as the quinolones, or drugs that can inhibit 3A4, such as fluconazole or ketoconazole, and patients who have a family history of arrhythmias. And also, we recommended patients don't take grapefruit juice, which would increase the bioavailability of the drug during our study. So, our study in 2001, since then there have been not a lot of publications in this area. One of the reasons is that it's very difficult to study, and you'll see why in a moment. However, there one study from Juan published 3 years ago where they also looked at 10 and 20 milligram dosing to see if there was a difference in the milk production. This was a short-term study, I think it was less than a week, and there were just 4 patients, which was a crossover. And they showed an increase in milk production, but no difference between the doses. The numbers are so small. And then another question came up. If you're increasing the milk volume, then does the composition change? And the nutritional components, does that change? And this was from Campbell, Yale in Vancouver. And they looked at the dose, the traditional dose that's used for 14 days, and they didn't find any substantial changes in the nutrient composition of the milk. So our dilemma was to find an optimal dosage of domperidone. Now we're back to around 2002, 2003, because we knew that 10 milligrams was better than placebo, but we didn't know if 20 milligrams was better. And that was relevant because that's what some of the physicians were using. So our primary objective was to determine if milk production is greater in the mothers of premature newborns who take 20 milligrams of domperidone 3 times a day compared to 10 milligrams domperidone 3 times a day for 28 days. And these are some of the secondary objectives. One was to measure the domperidone concentrations in the serum and the breast milk, to determine or measure the serum prolactin response, and we wanted to look at the milk plasma ratio and using an AUC model for that, and also to identify any adverse effects in the mothers or the preterm infants that might have been related to the use of domperidone. Our inclusion criteria, these women were identified by the NICU lactation consultants. So this was multidisciplinary with lactation consultants and NICU physicians and pharmacists. Was mothers of singleton or multiples who had babies who were less than 33 weeks gestation. The maternal age was 18 to 45 years. And if they had a daily milk production less than 500 mils between days 14 and 21, then they were eligible for the study. The exclusion criteria, if the mother had a history of breast surgery, breast cancer, a chronic debilitating disease, or an endocrine disorder that may affect the prolactin, if she had a family history of a clinically recognized arrhythmia because of the possibility of the effect on the QT interval, if she was receiving an antiarrhythmic drug, a quinolone, or a drug that was metabolized by CYP3A4, and mothers of infants who developed a disease in neonatology called necrotizing enterocolitis. So this was randomized. It was a computer generated. They were randomized in blocks of 2 and 4. And there were cards, which were sealed envelopes, were kept in the pharmacy, and the drug was dispensed from the pharmacy. So the mothers got 2 vials, and I think I'll show you the next slide, but they got 10 milligrams or 20 milligrams 3 times daily. And they got 4 weeks at this dosage. And we don't know, we still don't really know how long we need to go with this, or when we can decrease the dose. But what we did was we thought, from clinical experience, that a month would be good to try this. And then after a month, we went down to 2 times a day. And then after another week, we went down to once daily, and then the drug was stopped. The domperidone tablets, and we had identical placebo tablets that were supplied by Apotex. So each subject received 2 vials of tablets. In one vial, there was 10 milligrams of domperidone, and in the other vial, there was 10 milligrams of domperidone or placebo. So each woman would then receive 10 milligrams or 20 milligrams of domperidone. They used electric breast pumps to initiate lactation, like I had told you before. And so the woman had to pump 8 to 10 times for 24 hours. And they recorded their milk production for entire 6 weeks, each day, okay, each time they did that. So we might have 6, 7, 8 recorded times during the day. And she also wrote down the medication ingestion. So we were talking about compliance earlier. These women were incredible. For 6 weeks to mark everything down. And so that's the reason why these studies, I think, are so difficult, is to get people to agree to do that. And we also did some blood work. So the day 0, before they started the drug, they received, we took a sample where baseline prolactin was measured, and then after about somewhere between 10 and 15 days, depending when they could come in and whether it was on a weekend or not, they came to hospital, and we collected breast milk and blood samples over an 8-hour period. And we did some initial statistics. We thought that a sample size of 10 subjects per group would detect a difference of 50 mils in milk volume between the groups. And there were various different types of statistics, but for the primary research question, was there a difference in milk production between the 2 groups? We used the repeated measures ANOVA. In terms of the analysis, the domperidone in the serum and breast milk was analyzed by HPLC at mass spectrometry, and the prolactin was an automated immunoassay analyzer. Okay, so these are the results. You folks are the first ones to see this, and hopefully that in the next couple of months this will be published. There were 35 eligible subjects, 20 subjects declined, and there were 15 in the study, and 7 were scheduled to receive 20 milligrams of domperidone, and 8 were scheduled to receive 10 milligrams of domperidone. This is the demographic data right here. You can see the maternal age. They're 27 years old. Gestational age, whether they're smoking or non-smoking. This is the days between delivery and study entry, about 3 weeks, and the number of singletons or number of twins, and whether or not this was the first pregnancy or not, and then number of dropouts. And there are no statistically significant differences between those groups over there. So 8 years or so of work, and this is really the take-home slide right here. In the y-axis, we have the daily milk volume, and on the x-axis is the time. So weeks along the bottom. So up until week 4, they took the drug 3 times a day, and then between week 4 and 5, it was twice a day, and between week 5 and 6, it was once a day. There were no statistically significant differences at this point, although it looks like there is a difference, maybe 100, 150 mils between the groups, but statistically there wasn't a difference. And then these are the increases over that first month. Within the groups, there was a statistically significant difference. So that meant that the 10 milligram and the 20 milligram groups, they both increased in milk production over that 4-week period. Okay, and that was something that we expected that to happen, but it continued to keep going up until that 4-week period. However, what we were really looking at was between group difference, and that was sort of the crux of what we wanted to know. Is there a difference between the 10 milligram and 20 milligram group? There was no statistically significant difference between the groups. Okay, but you can see here at week 4, there's about 100 and, there's about 300 mil difference over there. So statistically, it's not significant, but again, our numbers are small. We thought that might have been the reason. But clinically, 300 mils is very significant. And then after, when we decrease the dose, actually between week 4 and 5 and week 5 and 6, there was no statistically significant difference between those groups, but it looks like between week 4 and 5 that it's pretty flat there, and this actually has gone up, but the numbers are small, but so this is, I don't see why it would go up, but it certainly hasn't gone down. So if that's the case, then maybe when the women are taking domperidone twice a day, then it may be just as efficacious as 3 times a day. But when they take it once a day, it goes down like that. Now, wasn't part of the study, but I think there were 3 women who actually after week 6, when they were not, that's when they stopped. 3 or 4 women in each, total of 3 or 4 women, and some in 10 milligram group and some in the 20 milligram group. So they had not taken any drug, and 3 out of the 4 actually had no changes in their milk production. So they maintained the milk production. For 1 woman, there was a decrease. So maybe at that point in time, then maybe it's reasonable for the woman to stop domperidone, but yet produce enough milk. We don't know that. We're just speculating. I acknowledge that the numbers are small, but it's maybe for a future study, as they say. This is the percentage increase, and the curves are reversed. Okay, this is the 20 milligram group over here, and I think that when you're looking at the percentage, it just reflects the larger amount that we started with in the 20 milligram group. So I think that first graph is the more significant one. This was the serum concentration at steady state, and our numbers are gotten down to very small. It's very difficult to do this assay, and some just logistical problems, but we did have 3 in this group and 4 in this group, and this is what you sort of expect. The concentration of the 10 milligram was about 12 or 13 micrograms per liter or nanograms per ml, which is exceedingly small. And then the 20 milligram group was about 22 or 23. So not quite double, but that's sort of in the area that you would expect it to be. And then we looked at the breast milk, and the concentration over here was higher with the 20 milligram than in the 10 milligram. Okay, again, 4 in each group. And we're looking at very small numbers and very small concentrations. And what we did then was do the AUCs for the 20 milligram group and the 10 milligram group. And this doesn't make sense to me. I would expect the AUCs to be the same, but it came up with double. And I don't know rationally how to explain that from a physiological. It just may be the fact that the numbers are small, there's variability, and we're dealing with very small concentration. That would be my take on it. And this is the prolactin, which was not unexpected. So this is the baseline prolactin in the 20 milligram group and the 10 milligram group. And this is at day 10 after the women have been taking it. So you can see a dramatic increase in the prolactin in both groups. There was a statistically significant difference between baseline and day 10 in both groups, but there was no difference between the groups over here. And again, if we had maybe more women, then that difference may have been statistically significant here, and maybe there is a dose response to the prolactin, and maybe that's why we see more milk being produced in that one group. So this was the first study to examine the 2 different doses, including a tapering dose of domperidone over a 6-week period. It demonstrated a statistically significant increase, progressive increase in milk production for the first 4 weeks. And so maybe the implication is that we start the woman on 20 milligrams or 10 milligrams and do it 3 times a day, and then maybe at week 4 we can go down to twice a day. Our primary question between the group differences was non-statistically significant, but clinically significant, like I had mentioned before, 300 mils between the 2 groups. And if our numbers had been larger, then there very well may have been a statistically significant difference as well. So the conclusions are that an increased dose of domperidone produces a clinically significant increase in milk supply. Our results likely failed to reach statistical significance due to the low number of subjects. And twice daily dosing of domperidone may be adequate to produce clinically relevant increases in breast milk. I think we saw some nausea and vomiting in one woman, and it was recommended she just take the medication with food, and then that was all. It was fine. We didn't see any other side effects, but again, with 15 women, that's a very small number, so you can't really make too much conclusion from that. So future studies, and I don't know who is going to do this because it's exceedingly difficult and very time-consuming, but maybe there's some young investigators. So one question is twice daily dosing adequate? What's the optimal duration of therapy with domperidone, and are increased doses and prolonged duration of domperidone therapy safe to the mother and baby? So I think we've given some direction to this, and those are questions that probably really need to be answered, because this is used quite regularly in women who have difficulty producing milk, especially in their premature babies. I'd like to acknowledge an unrestricted educational grant from the Canadian Foundation for Women's Health that was courtesy of Duchesne. That was we received that around 2003, 2004. Also Apotex for producing the placebo tablets for us. And co-investigators, Andrea Page, who was a medical student at the time, did a lot of the work with Health Canada so that we could do the study, and Jamie Seabrook, who did our statistics. And then we had 4 lactation consultants, Michelle Angelini, Joanne Warren, Michelle Carr, and Diane Killick. And they were the ones who did day-to-day stuff, did all the collection, and really, without them, it wouldn't have been possible. And then one of our neonatologists, Dr. Orlando da Silva. So I thank you for that, for your attention, and I'd be happy to try and address any questions you might have.
Clearly, you had quite a lot of variability. Well, you had a 300 mil difference, you said, but there must have been quite a range of milk produced between the lowest and highest in the range.
I don't have those numbers right off the top of my head, but you're right. There was variability, yes. And with those small numbers, we could should have shown you the mean or the median. But there was variability. But there was definitely, certainly, there was a trend to a higher dose with that 20 milligram dose.
David, can you go back to the primary endpoint slide, the 2 areas?
The curve?
The curves. If you see. When you said that they were not significant, what do you mean? It's per point, point per point per point, or area under the curve?
No, they're compared at the points.
Yeah, but that's you're punishing yourself. You're interested in the area under the curve of milk, and I bet you that they're highly significant.
If we did the AUCs.
AUCs of milk production will be highest per each point. Your variability is large enough to kill it, and you need much larger numbers. But I know it's not appropriate to change primary endpoint. I think what you're interested in is really area on the curve of milk production, and I bet you that it's less than 0.01, based on experience. Yeah. You punished yourself. You took the most restrictive endpoint. You're not interested in day 1 or 2. You're interested overall, and I tell you that it's highly significant.
Thanks, Kitty.
Very simple question. The only side effect which you have observed was nausea and vomiting. It was different in 2 groups, 20 milligram or 10 milligram, more with the higher dose?
That was just in one woman, and I don't remember which group she was in, but that was minor, and that was the only thing we saw. But again, it was only 15 women.